Welcome, everyone, to today's panel discussion, Create an Innovative Clot-Busting Program, Learn Best Practices to Prevent VTE. I am Molly Gamble, today's moderator, and on behalf of Becker's Healthcare, thank you very much for joining us today. Before we begin, let's walk through a few quick housekeeping instructions. First, you can submit any questions you might have throughout the webinar today by typing them into the Q&A box you see on your screen. Today's session is being recorded. Will be made available after the event. You can use the same link that you used to log into today's webinar to access that recording. And then finally, if you have trouble at any time with your audio or video, try refreshing your browser. You can also submit any technical questions into that Q&A box. We are here to help. With that, I am pleased to introduce our terrific speaker joining us today, Dr. Amy Campbell, Quality Nurse Specialist. Thank you, Amy, for being here today and taking some time to visit with me on this really important topic. Before we dive in, can I ask you to take a moment to tell us a bit more about yourself and how you got started as a VTE prevention champion?
Thank you so much, Molly. And it's such a pleasure to be here and just sitting down and talking with you about one of my favorite subjects. So I've been a nurse for 24 years. I've worked a little bit everywhere. I'm from Eastern North Carolina. This accent is real. I work in a 9-hospital bed system. One of my hospitals is actually a trauma one. It's over 1,000 beds. And I think over time in my work, I just had a morbid curiosity of why are these blood clots occurring? We have some of the best healthcare in the world. And why is something that could be so preventable just keep happening? And it's not just a lot of times we have this urban legend, it's the older person that has a blood clot. It is our younger population that has blood clots. Anyone can have a blood clot when they meet certain risk factors. So I just got involved with it, and then I got really excited about it because I was able to see a lot of times in performance improvement, it takes a while. You do a lot of PDSA cycles. And I really just working with the units could see stuff happening pretty quickly. And we were able to really set some processes in place and decrease our numbers. And, you do have shifts. We'll have a year we do really well, and then maybe we bump up. But overall, we've just had some really great work. And that makes it exciting. Everyone wants to see you do things that improve patient outcomes.
Very much so. Well, you hit it, Amy. There's some misconceptions around this topic. I think probably some underappreciation of its scope and impact. So we're going to cover a lot of that today and more. But let's begin by better understanding this pathophysiology of VTE. Can you explain that for us and then also touch on the methods that are most commonly used to diagnose it?
Yeah, absolutely. So I feel like if you understand the pathophys, then everything else kind of falls into place. And I tell the story very similar if I'm talking to a family member or a new nurse or someone who's very experienced in healthcare and they're wanting to know information about it. Blood clots normally are good. That's when you're bleeding or you cut your finger while you're, cooking. You want it to clot off. That's what should happen. But every once in a while, you meet something called Virchow's triad. And I always talk about SHE. If you can think about stasis, hypercoagulability, and endothelial injury, when you get those risk factors, then you can form a blood clot. You can get one in your leg. That's your deep vein thrombosis. And that's when the their calf starts bothering them. And it might get red and they start talking about pain. And then if we don't intervene and when it's in the leg, you're going to do an ultrasound. Usually it's bilateral. We're going to compare both legs and we're going to look to see if we can see the embolus. From there, if it's not treated, it actually can travel and go up to the pulmonary artery. And when it goes there, now you're affecting the oxygenation. Your oxygen levels are going to go down, your pulmonary pressure is going to go up, and you're going to have damage to the heart and lungs that could be deadly. What we will look for there is with usually a CT or CT with contrast. Sometimes we look at D-dimer. D-dimer is the protein fragment your body makes when the blood clot dissolves in the body. So that's kind of, D-dimers, it depends on physician preference. Usually they'll go ahead and try to get the CT and we're trying to act right away so then we can intervene. But I think if it starts in the legs, it can come up. Occasionally you can have it in the arm, and that would be from when you've got a central line, like a PICC line. That could also be your upper DVTs that you have, but mainly I spend most of my time looking at the lowers.
And just for our listeners, a few stats here to help us understand and put some context around VTEs. Each year, an estimated 350,000 to 600,000 patients are affected by VTE. This results in approximately 100,000 deaths. Less than 50% of hospitalized patients receive appropriate prevention measures. Amy, beyond these statistics, why do you see VTE as a problem that you have so heavily focused on? What's the bigger impact here that we should appreciate?
Well, and I think one patient's too much. I think stats are absolutely wonderful and it kind of puts it in perspective, but 50%, and I would even say at times it may be even higher than that, and 25% of our instant deaths. This is where you hear those stories, someone's out running and something happens to them, and then we think they've had a clot. I think those statistics should motivate us and they should kind of make our ears perk up of why is that happening in our institution and how can we take better care of our patients? It gets to health equity, regardless of where you are. And I had the opportunity to participate in World Thrombus Day. And what was great about being on that panel is we're all struggling around the world. So wherever you are in the world, we should all be trying to assess your risk and prophylax appropriately.
Amy, in your work as a quality nurse specialist, I imagine you are collaborating with many different team members in caring for patients. Where do you begin by pinpointing opportunities to make improvements in care quality that can lead to improvements with VTE?
Yeah, I think when I first get the phone call or the email, we've got a VTE or we've got a VTE problem, I really define, do we, like let's really dig down. Let's determine what unit, let's use the Pareto rule where you're going to focus on 80% of where your problem is and focus on those 1 or 2 units. And then really dig and try to understand what is going on here. Is it more DVTs? Is it PEs? Is it happening? What day? Is there a certain day that we seem to have more on? Like is it post-op day 2? Is it post-op day 3? Is it an intensive care unit? Really, I call it shrekking it. You're digging those layers of the onion back to understand the DVT and PE, and is it a problem? And again, 1 is too many. So, when you have 1 and you call me and you have a concern, let's work on it because you still have that, sometimes low volume, high risk in our really small hospitals. It's still too many. You may not have a clot busting program in place. So I really just try to understand, take a moment, step back, and really understand where is the problem coming from.
Mm-hmm. And then we should also touch on the fact that in addition to a large and diverse care team, you're also seeing an array of patients. And you had touched on this misconception in your opening remarks about how a lot of people equate this as an older patient, an older population problem. How do you ensure that you're assessing each patient's risk for VTE properly? And what can be built into the EHR to help standardize that?
That's a great question because really anyone can throw a clot. Anyone can throw a clot. If you think about it, anytime your blood clots naturally, then you know that it can go in the wrong place. So we're seeing 1 out of 200 of our pediatric patients are having blood clots. Now, I know you're going to say, Amy, how do we keep the sequential compression devices on a little person? And I worked peds, a long time ago, and it would be more for the patient that's not moving, right? Most of our children are not going to have them because they're moving so much, but it's that risk stratification. Thinking of things like the Caprini score is one that's very popular. It is research-based, and it helps to guide our providers on, is this patient really at risk? If everybody is at risk and everybody's getting SCDs and everybody's getting Lovenox and they don't need it, then that's not appropriate either. Then you're going to have trouble finding your equipment, or you're going to risk the patient developing bleeding problems because they're getting all this prophylaxis that they may not need. So it's just things to think about when you're going through and you're risk stratifying. And I always tell the story. I have too many stories, unfortunately, but what breaks my heart is to see someone really young that, when we're 21, 22, we're invincible. I have a 21-year-old. He's invincible. They put on the cape. They cannot imagine they would have an old person blood clot. And they get in an accident. They come in And we do an amazing job with them in our intensive care unit. They go through multiple surgeries. They overcome so much. But when they start waking up, the first thing they tell us is, take those things off my leg. I don't want those. I don't need those. I'm refusing those. And it's so hard for them to convince them the importance of, you right now need those. Now, when you talk about prophylaxis, the best thing is chemical. Lovenox, your heparin, your anticoagulation, that's going to work so great to actually go and break up the clot. However, there are times when people do have things where they can't tolerate that. And the best prophylaxis is going to be chemical and mechanical. And that is, I call them the huggers. That's the squeezers. That's the compression devices on your legs. But you take that young person who is refused, who doesn't want to wear them, and then we finally give them up to walk and they throw a clot and have a terrible outcome. After all they have been through, they've survived a terrible car accident, they've had wonderful ICU care, they're on our trauma unit, they're doing great, and then we ambulate them and they throw a clot. And that's devastating. And I tell that to a lot of my young people, that you are at risk. You are laying here, the medications you've had, you are at risk for a clot. And we've done so much to keep you healthy and get you home. Let's not miss that now.
Right. Can you repeat for me, you had a stat there in the early portion of your remarks about the pediatric patients. Can you repeat that one more time?
It's 1 in 200. 1 in 200 can have a blood clot. And so that even makes you want to think more about, how can we make this pediatric friendly? I love the pediatric population. I started in children, so it's definitely got, a big place in my heart. The new pediatric sleeves, you can even color them. You can work with the child life specialist and make it fun and say, hey, you can do that with the adults if you want to. I've done so many creative things to try to keep them to wear them, to just understand the importance of, you are not moving, and I've got to increase that blood flow for you.
Mm-hmm. Well, let's move on and talk about action and beginnings and starting a program to reduce and prevent VTEs. My first question, Amy, if you were brought in to consult a hospital with a high VTE rate, where would you start? Can you tell me about how you would organize your approach when first beginning and setting out on this effort?
Yeah, absolutely. I would be excited, not that you have a VTE problem, but that I feel like with your team, we're going to be able to do this, because I feel like that you would first start and look at your stats, determine, is it PEs, is it DVTs, and where is my unit? And then I want to try to get to the root cause. And root cause is a lean term. You can do RCAs, but lean talks a lot about 5 whys. Doing those 5 whys so you can get down to what the root of your problem is. If you don't understand your root, then we're going to stay on the merry-go-round. And sometimes that's okay. We're going to try things and go, you know what? That's not the problem. Let's go back. Let's go back. Let's keep looking at it. From there, I want to set an aim. Like, what is our aim for this? And you want a SMART aim, which is smart, measurable, obtainable, relevant / rewarding, and timely. You want to set this up so everyone knows, what are we trying to do here? I want to decrease my VTEs by 10% by April 15th. That's a little bit crazy goal, but maybe June. But you want a goal for everyone to know, what are we working towards? Then you want to build a really great team. And this is it could be your unit-based counsel. It could be you bring in a quality person, you bring in a nurse leader, you bring in some nurses. One of the things I do when I'm brought in is almost immediately, as I'm trying to explore the problem and really understand it, is I do a focus group. And this usually involves me sitting in the lounge with some pizza. And I just ask people, hey, tell me about your SCDs. Are they available? Do you know how to wear them? How long do you keep them on? What are problems? And the nurses usually will give me more than I want to know. Just great information. I'll work with the nursing assistants. And so I kind of, a lot of times if I feel like I've got some champions in there, I'll also pull them in to my actual work group. And then from there, we just start piloting, and you try to do one thing at a time. You don't go crazy. You've got to educate. Now, everyone will say education's not performance improvement. It's not. But if people don't understand, then how can you validate and verify a new process? So I usually start off with a real robust education program. We walk around. I've learned as I'm getting older, I have to evolve. I just did something like a TikTok for one unit. We made it a QR code and then we put it on their wows, which is their computer stations that they walk around with. And so now they can scan it and they get a little 2-minute clip of me telling them about VTE prophylaxis and then where do they need to go on their unit? What are their resources? So I educate. Then from there, we implement 1 or 2 things at a time, have a charter, have a timeline, and then you're going to PDSA it. So you're going to plan, do, study, act. You're going to plan it, you'll do it, you'll study the results, and then you're going to decide if you're going to change it. And usually we just do small things at a time until we build up some standardization. And then from there, we just build great behaviors that lead to processes. Everything about quality, everything we're trying to do is trying to change behaviors. So I just try to change and build really great behaviors. So when the SCD pumps arrive on the unit, everyone's excited about them. We got to get those on. They're not going to sit there for a couple hours. There's a sense of urgency. This patient needs this. We need to have those on.
Mm-hmm, mm-hmm. I mean, a lot of moving parts, I think, as you just touched on. And I'm curious too, because as we're getting started here, as leaders are getting started, an approach doesn't necessarily equate to a program, right? Those can be two different things. Can you help differentiate that a little bit? After you've strategized, you've kind of decided on the best approach, what are the next steps you would take toward building a true clot busting program?
Well, I think you've got to build your tool set, your toolbox. What is working for us? I think you need to look at your protocols. And from there, like I would start with how are we doing with assessing the patient when they first come in? So when you think about your program and when the patient first comes in, what is our protocol? How are we prophylaxing patients when they walk in the door? Are we doing anything before they come in? I'm really big on, can we start some pre-walking and pre-movement before they even come into the hospital if it's a planned surgery? Because if there's someone who doesn't move and then they get me and I'm going to make you move, that's hard for them because getting up to the chair is not ambulation. We need them to be up, going to the nursing station 3 or 4 times, giving the secretary a high five, and having really great movement. So with the programs, you need a standardized approach that we're going to take care of every patient. And we're going to figure out how we're going to prophylax them. And there is some leeway with that because your surgeons are going to use whatever their governing body is going to tell them. We do use the chest guidelines, but orthopedics may have something very different from what a transplant's going to need, and that's okay. But we have a standard approach for how we're doing it. Then we are doing what is ordered. That's a big piece of the program is what the physicians do risk stratification. They determine the patient needs SCDs and they need Lovenox twice a day. Then the nurse, how is the nurses going to validate, verify, and make sure they're doing what is ordered? So a lot of times the charge nurses will add it when you were talking about earlier, what can you do within the EHR? A lot of my nurses add their VTE prophylaxis to their My List. So when they go in, they know they have VTE prophylaxis ordered and what it is. The charge nurses make a list, and then when they're rounding on patients, they're already saying, okay, does Ms. Campbell have her SCDs? Do they have her Lovenox on? It's also kind of like a safety net for the nurses. Then from there, a lot of my nurses are included in their bedside shift report. They're asking, is this patient getting VTE prophylaxis? Yes or no? And how are we doing with it? And if they're saying, you know what, she hates wearing them during the night, or he's not wearing them during the night, the next question is, what are we doing about it? Are we letting the physician know? Where are we documenting it? And just doing that follow-up. So I think it's aligning your best practices, your evidence-based practices, and coming up with very simple programs. We're going to educate, and then this is why I say I think clot busting, and it's easy, and it's not as complicated as maybe sepsis and some of our other programs that we have. You're going to educate, we're going to risk stratify, and then we're going to do what is ordered, which is going to be given that chemical and mechanical prophylaxis. And then we're going to develop some type of surveillance system to make sure that we're validating and verifying what we're supposed to do.
Mm-hmm. I'm picking up that simplification is really important and also
Mhm.
standardization, ruling out variation where you can. So with that in mind, we talk a bit about protocols? What nursing protocols? You made mention of a couple there, but I'm curious if there are others worth mentioning that you've implemented related specifically to VTE. Thoughts on how to best standardize care around this?
Yeah, there are different protocols out there. Some are actually built in the EHR where the nurses are doing some risk stratification. There are many protocols out there when the nurse assesses the patient. If she feels like he or she feels like they need SCD pumps, they can go ahead and order them. They don't have to wait. Now, I have done just a critical thinking check is make sure they don't have anything going on in their legs where they shouldn't have an SCD on. For example, they have a trauma, they have an ulcer, they have a graft, they've had something, or they already have a DVT. There's different research out there that says whether or not you put it on. But if you have that in your protocol, just pausing for a minute. There are different ones out there. Most all of them are going to tell you to risk stratify, determine if they have risk, then coordinate it if they in your EHR, if you have a mobility score, looking at a certain score and saying, okay, this patient needs to move and groove this many times a day. And then when they're in the bed, they need to have their SCDs on. And then we need to make sure they're getting their prophylaxis. The physicians wanted, they have the Caprini score, there's iBled, there's different things that they can use to determine. One of the most common ones that I'm familiar with is Caprini. And all those can be built within your EHR. Now, you may say, well, Amy, I don't have time to have a protocol built. That takes time. You're absolutely right. So in transparency, some of my hospitals do not have the Caprini score built in. So when I get a DVT or a PE that happened, what I'll do is go online. You can find the Caprini calculators online, and I just answer all the questions, the risk stratification, and I get a score. And then I can give that score back to the physician. And that is an excellent objective thing you can share with them. There's a saying, in God we trust, everyone else we bring data. And I think it's important to have your stories and your emotional appeal, but I think it's really great to have numbers so you can objectively look at a patient and go, okay, yeah, I see what you're saying here where we had opportunity.
Mm-hmm. Mm-hmm. And let's talk too about misses, right? Or near misses. That's going to be really
Mhm.
important to a program like this. Detecting and identifying what could be a missed opportunity throughout the treatment plan or a discharge that could then contribute toward a readmission.
Right.
What are some spots that people should be looking for and care teams should be looking for?
Yeah, so let's start with admission. On admission, not knowing the patient already has a history. And sometimes it's funny because I've had patients and I'll come back to them 3 days later. I'm like, you have a history of a DVT? And they're like, oh, yeah, that was years ago. I didn't even think about it. And you're nervous and maybe it's been an accident. There's a lot going on, but a lot of it's in our intake. When we're talking just risk stratifying there, is there cancer? Is there hypercoagulability? Is the patient on birth control? What are things that make them at risk? Is there endothelial injury? Have they had COVID? There's some things to look at that could place them at risk. So what are we doing when they first come in the door? And then are we teaching them from the very beginning? When you come out of surgery, you're going to have these things on your legs. Or when you get up on the floor, you're going to have these things on your legs. Or when you're in the ER, we're going to put these things on your legs and we need you to keep them on. The other thing you're going to do is probably be getting a shot in your belly. And you may not want that, but this is a life-saving measure. I've seen the nurses go in the room and say, Miss Smith, do you want you want the shot in your belly? And she goes, no, I do not. And I would say the same thing. So a lot of times I'll go right back in. I'll say, let's go back in. I'll say, Mrs. Smith, do you understand that what they're giving you, that little bitty needle is life-saving, and I need you to do that. So some of it is proactive. What can we do in the very beginning? Then when the patient gets on the floor, understanding what is ordered and why it's ordered, and do we already anticipate there may be some problems? And let me tell you where I anticipate problems. When someone comes in who already has a lot of risk factors, surgery is one of them. Anytime, keep it simple. If they're not moving, they're at risk. You just know that. If you have someone that's bedridden, and I look and I see what have they ordered. Maybe they've just ordered Lovenox. Maybe they've said to hold Lovenox before surgery. Sometimes, now that may be that surgeon's preference, but a lot of times when we've gone back and asked, when they haven't ordered it, they'll order it. When things get held, that is a near miss, because sometimes what happens, we may have held it because the patient did have some type of bleeding, they were hemodynamically unstable, they were getting ready to have a procedure, but then it falls off the MAR, the medical administration record. And then what happens? The patient now goes 3 or 4 days and doesn't have prophylaxis, or they get moved to another unit and it falls off. So keeping it simple again, you're proactively going to be thinking about it. Do they have a history? Do they have a risk? And then when they're on my unit and I'm taking care of them, are we giving them everything they're supposed to get? So making sure we don't miss doses on medications. If the patient refuses, let's say I go in there and talk to Miss Smith, I give her the best story, I tell her it's life-saving, she goes, nope, not going to do it. Then I need to write refused, educated, and provider notified. I'm not telling you to call surgeon at 2 in the morning to tell them you didn't give the Lovenox, but when they round again, we need to make sure we have that documented. The other thing is with your compression devices, really encouraging the patient to keep them on, troubleshoot. If the pump is not working, it's beeping, turn it off, turn it back on, simple solution. But then also look, do you have a break in your tubing? Are the sleeves not on right? Really look at the machine. Just don't turn it off, because what will happen, because life happens, you turn it off, 3 or 4 hours go by, maybe even a night, and we have had nothing, no compression. And this is the same patient. Maybe we stopped the Lovenox on. So those are all breaks. Basically, you do what is ordered. And if we don't do what's ordered, we're letting our providers know, and we're doing a lot of education with the family about the why.
That's a big tenet of what you just shared there is aligning expectations. And so people know, like you said, no one's going to be clamoring for a shot in the belly.
Right.
But if they understand what it's for, it could be a different result. You know, Amy, as I was preparing for our discussion today, I came about this note about PSI 12s. Can you describe what that is and how it ties back to this topic and also to reimbursement, which I know our listeners will be interested in?
Right. So we're at a different age now where our care is being reimbursed. So if something happens that's considered hospital acquired, we are not reimbursed for it. It also goes in our public reporting, and our patients are consumers. They want the best care possible. So they're looking at what are your patient safety indicators and how are you doing with them? Am I going to get the best care when I come to your hospital? And it also goes back to health equity, which we want for all of our patients. So PSI 12 is your patient safety indicator for perioperative VTEs. It's not postoperative. So it means any patient coming in with a procedure, and once they get in the holding cell or holding period before surgery, and they end up having a VTE, we're going to get that PSI 12. And so that is something that we spend a lot of time within my system working on. We have a very robust way that we do it. First, it goes to a work queue that lets me know, okay, this patient has a PSI 12. Then we match it up with the codes the AHRQ has given us that says, okay, this is included or it's excluded. Spoiler alert, most things are not excluded. I'm always like, well, maybe it won't be a real one. They usually always are. And from there, my surgeon, I have an interdisciplinary team. We have a surgeon that looks at them, pharmacy, nurse leadership, my lens, and then even sometimes the nurse from the floor, and then it's reported out at our PSI meeting. So this takes it to another level. Most importantly is we give the best care for the patient. But as we are coming hospital-based purchasing, we need to think about how does VTE fall in that, and how does it fall to our reimbursement? For many hospitals around the country right now, it's an imperative. It's one of the main ones that they're focused on.
Well, let's move on. We've been talking about prevention, detection, education, the program, and building one, but let's also talk now about when a VTE does happen and you're conducting a drill down. What should you be looking for when you are doing that drill down? What variances should you be keeping an eye out for and paying attention to, Amy?
I think one of the best things, I call it a live autopsy, but the live drill downs are the absolute best. If you can develop rapport where your unit will let you know, hey, we just had a DVT or a PE, and you can go up and actually round on the patient, talk to them about their experience, because then that also gives you a great story that you can go back and tell your committee. But then you can look to see in the chart with the nurse real time, how was the SCD documentation? Did we miss Levinox? So what do I look for? Kind of going back to, did they have risk factors that we could have missed in the very beginning? Did they have a history of DVT? Are they a readmission? Did they just go home and come right back? How many surgeries have they had? What is there anything I can say led up to this that we should have probably called? Then from there, we're going to go and look to see, what did they get? Did they get any prophylaxis before surgery? How long was their surgery? Is there anything that we gave them during surgery that could possibly increase their risk of clotting? Then I'm going to look at, how was the documentation of the SCDs, the sequential compression devices, afterwards. Notice I said the documentation, just, because I that's what I'm looking at. A lot of times I'll round on units, I see the SCDs are on, but then when I'm looking at the drill downs and I'm going back to look at their prophylaxis, it looks like we refused, and then we also didn't take the medication. And this is just not the best thing for the patient. And that may not equal the care that was given, but that was what was documented. So what I report out are, were there clinical deviations in care, yes or no, and what they were. And it usually, honestly, is SCD documentation, or we didn't educate, we didn't notify the provider when we weren't given what we were supposed to.
Okay, that makes sense. Well, by the sounds of it, I mean, if things were this easy, right? Maybe the rate of VTs wouldn't be what they are. But let's talk about barriers, because this is what can make this work really difficult and
Right.
limit the results you want to see from a program. What are some common treatment barriers that you've encountered, and then how have you worked around them or to overcome them?
Well, ICU nurses that have a heparin drip do not feel like they need SCDs. And I've worked ICU, so I understand that. But there's a teaching moment there, because is the chemical prophylaxis the best? Absolutely. But there's going to come a time when they're going to probably get off that heparin drip. And we might DC the heparin drip altogether. And we don't want a space in there when they don't have prophylaxis. So I'm always teaching about, even if they have Levinox, even if they have heparin, if they have a heparin drip, you have chemical prophylaxis on board. If the physician has ordered compression devices, they need to be on. So that's one of my barriers. Sometimes it's family. Family says, you know what? I don't want grandma getting that shot in her belly. She's already uncomfortable. I don't want her doing it. And it's really doing a lot of education and kind of saying, okay, I'm going to not do Levinox now at 8 o'clock, but I'm going to come back at 10 to see if you've maybe changed your mind. Maybe you've had maybe they're in pain. Maybe there are other things I'm battling. And I'll try to come back and say, okay, you want to try again? Can we do this? And then trying to get them up and moving and walking, that is a barrier, because some of our patients, we have very little nurses, and the patient may be larger for them, and we don't want to risk a back injury. So learning how to move some of our patients, getting help. I'm fortunate in the system I'm in. One of my hospitals has a lift team, so they can help with that. But again, just getting the patient up to chair is not ambulation. Some of my floors that have worked through this barrier is their nursing assistants are really great at walking, and they start at 5 in the morning getting all these patients up to walk. And guess what? The units that have great walking and mobility protocols have low VT rates. And it's not a secret. It's just what you're doing. So those are the barriers that I see. I'm really fortunate to work with physicians that are very engaged. Sometimes physicians will say, I don't order this prophylaxis because in this population, I'm concerned with risk, them bleeding out, spine, some of our surgeries that lose a lot of blood. And I don't really see that as a barrier. I think it's a time to learn from each other. So when that happens, we kind of dig into the literature, and I'm like, okay, show me what your body, your organization, your governing body, orthopedics, transplant, what are you currently doing, interventional radiology, and what are we doing across the country? I find that all of us are struggling with compliance with the SCDs, and the only way we're going to get good with that is just to keep it in front of us and keep auditing it and just keeping that number. You know, you're currently at 11%, you're at 20%, you're at 30%. And when we hit a certain number, we're going to celebrate it and make it a big deal. But there's so many times we don't see the SCDs as life-saving.
Mm-hmm. And these sleeves have come up a lot throughout our conversation so far, and also the varying attitudes about the sleeves and toward the sleeves. Can we talk a bit about the sleeves in more detail? What's the goal time for a patient to wear a sleeve? Is there a range?
Yeah, so depending on where you look in your research, with the compression devices, honestly, the research is not as much as we would want it to be because it's not as much research out there. But we know there's enough research out there that shows that this pneumatic compression device, what it is applying to the legs, it is causing us to have blood flow and prevent stasis. Now, you'll hear 18 to 22. At my organization, we say 22 to 24 hours. We basically want you to break for therapy and bathing and the rest of the time them to be on. Now, that's also using some critical thinking. We don't want to get pressure ulcers from, having the sleeves on. So a lot of my nurses during their bedside shift report, when they're going in, they release the compression devices, check out the legs, talk to the families, talk to the patient, use it as a teaching moment, and then they start them back up. It's also a great time if you have the controller with the right software, you can actually look at the compliance and zero it out. So it's a good time to do that as well. But the compression devices are great. They're good for the patients. They're good for them to have on. And I really think if they just give it 3 or 4 hours of wearing them, they'll forget they have them on.
Mm-hmm. And you've talked, Amy, about education around the sleeves. Any other do's and don'ts you would share about helping patients see the purpose of them, help improve and strengthen compliance when you can? Anything that you've seen as be especially effective or ineffective?
Well, I think them understanding the importance of it, don't give up on them. Sometimes people won't wear them for a few hours, and I don't want to use the word nag, but if you're persistent, they'll usually be like, okay, let me try them, let me get on. When they really get into it, it's kind of like having your vegetables and eating well. We don't want to do it in the beginning, but over time, we're like, all right, maybe this is making me feel good. And so I just keep trying to work with them and also problem solve. If you don't want to wear those, can we do foot pumps? Can we do stockings? Let's just not do anything. Let's just keep the conversation going, trying to keep rapport with the patient as well. But also, a lot of times we try not, if you say, are you going to wear the SCDs or not going to wear the SCDs? They're going to say no. I don't want to do that. I mean, so you really don't, I don't like to give a lot of choices. So I always try to make it positive, like, oh, Miss Smith, this is fun. You got your SCDs off. Let's get those back on. Let's get this going. This is part of your healing. This is part of you going home. And we mentioned something earlier when you were talking about things we want to make sure we're doing at discharge, that I feel like there's always opportunities when the patients are going home is building up rapport. These medications that they sometimes go home on are very expensive. So sometimes patients won't tell you, I'm a little worried how I'm going to pay for that. How am I going to cover my stockings? So that's something you want to build enough rapport and spend enough time with them where they understand, hey, this isn't something we can just stop taking. This isn't like I'm taking a Motrin today because my back hurts. In a couple of days, I'm going to get off of it. You need this. This is life-saving. You don't want to go home and stop taking this and you throw a clot and you're in a bad place where we can't, where you can't get medical attention.
Right. Sounds like the yes and spirit is alive and well in those conversations about the sleeves. And then to your point, understanding, being realistic about compliance too at discharge. Amy, this has been such an educational conversation for me, and I'm sure for our attendees. We have some time left, and we've gotten some questions from our attendees. So if you're okay, we can move on to some of those and see what questions they have for you. Okay, terrific. So the first one that came in, you spoke about data. What data do you find most helpful to start with to see where we can improve? And then what data do you use to track progress with?
Right. So when you think about your metrics and your key performance indicators, you're going to start, I'll go a little bit backwards here. You think about your process measures. Process measures are what you do every day to improve your process. Like if you were trying to lose weight, this would be, you're going to run every day, you're going to weigh every day, you're going to do your measurements, you're going to eat good. That's your process. So what are things you're doing in your process every single, for every single patient? We're wearing the SCDs. SED compliance. We're giving the medication ordered. Those were things I would look at. Then you also may want to look at, are we doing some kind of risk stratification, and how many patients are receiving that? How many patients are walking? Those are all process measures that all lead up to your outcome measure, which is your VTE, which could be a PE or a DVT. So I look at my process measures, how that leads to my outcome measure, and then I kind of look to see, do we see more DVTs or do we see more PEs? Then from there, you can even get more granular and look to see, is it a certain population that we're seeing more of? Like, is it 65 and older, coming from a skilled nursing facility that has this heart condition? I mean, you know, are you seeing some type of pattern that you can maybe trend down to, especially if you're overwhelmed and you've got all this data? I would try to encourage you to get down to the granular level, focus on that population, get that down, and then move on to the next one.
Great. Thank you so much. It sounds like when we were talking about patient refusal, at least one attendee can relate to that. This next question: after completing a risk assessment, an obstacle we often encounter in my department is patient refusal of treatment. What recommendations do you have for monitoring patient adherence to the recommended CHEST guidelines for IPC and encouraging patients to take their medications?
Yeah, I think there's lots of opportunity to be creative. I've had, one of the things I did was I wrote a grant, Socks for Clots, and we did a project in a box, and we had socks and markers and fabric stickers you could put on the fabric. And then I did a little QR code with me explaining it. And then they made a bulletin board. Now, this is not going to be for everybody, but there's a lot of research out there for burnout and resiliency and tying art to quality improvement. So what the nurses did is they made socks on prevention, and they also got the families and the patients involved. Like, I'm wearing my socks for my baby, you know, for like on the maternal side, or I'm wearing my socks so I can go home. And so that is one fun way that, you know, in the South, we say you get more sugar than with salt, you know, with sugar than salt. And so that's one of the ways you can do it, is trying to come up with creative things, asking one of my units. They do like almost a competition to see how many audits they can give, and and a lot of times the families are like, and the patients, I don't want you to lose, I'll put the SCDs on. So you can do creative things. I think it all comes back to, we want to get you out of here, reinforcing the why. We've done so much. Think about what all you've been through. You've gone through surgery. You've gone through all these procedures. We know you want to go home. Let's not throw a clot here at the end. My physician partners do a great job just going in, sitting down on the bed, talking to the patient, going, hey, why don't you want to wear them? And a lot of times they're frustrated. They're tired and they don't feel good. And they're like, I just want to go home. Guess what? We want you to go home too, without a clot. So let's wear the SCD. So I think be creative, reinforce the why, and don't give up. I've had people refuse me for the first couple of days, and then finally they get into it. And I tell them, the more you wear them, the better you're going to feel. And then I can get you up walking. And if I can get you up walking, we can probably DC them.
Probably related to the creativity piece, this next question around morale and excitement from an attendee. I'm on the VTE team at my hospital, and I'm looking for ways to get staff excited about DVT prevention. Do you have any creative ideas for clot busting programs you've done at your facilities? You mentioned art, Amy, and infusing some personality and even fun into these efforts. Anything else worth mentioning along the lines of creativity?
Well, I just think that different people like to do different things. Some people will love doing the audit piece. Some people will like doing the creative piece. Some people will like doing the abstraction piece. But you have to be very intentional in your approach, but it doesn't mean it's going to be very time consuming. That's what I always sell when I'm trying to get people to join my clot busting teams is, let's come up with something that'll take us 20 or 30 minutes to do. And let's do it very quickly. You could do games. We've done bingo. We've done the move and groove. Every time they go around the nurse's station, they get a star, and then we put it up on their board for them. We've done things where, you know, how long did you wear your SCDs today? One of my units at one of my hospitals did something, a squeeze ball, And so, how long they could keep the STDs on and having a competition. I think the sky's the limit. Have fun with it. Process improvement should be fun. It's a very serious subject, but sometimes it's very daunting when you think, I've got to go look at 35 patients to see if their STDs are on. And I would say if I was tasked for that, I'd say, all right, let's bring in donuts and say, you don't know, like donut, how much we appreciate you. Put out some VTE literature, then let's recruit people to help us, and let's just make it a fun day, and we'll get it all done in an hour than me trying to do it all 35 by myself.
Sure, sure. I feel like the way you just quickly recall that donut example, you're a font of different strategies. So thank you so much for highlighting a couple for us. And then finally, the last question from attendees that we have time for today, how have you had success involving physicians in your clot busting programs?
Well, I'm very fortunate. I work with amazing physicians. They're very involved, but they're also very busy. So I think for us, it's been a partnership of listening to each other, learning from each other. I need them to review my PSI 12s, and they're going to see things and understand things that happened during the surgery that I don't understand. And I'm going to see things that happened on the nursing side that they're not going to understand. So I think really it's also showing them their data. When you send it and they realize, whoa, I had a VTE, physicians are competitive, but they also want the best thing for their patient. They don't want that to happen for them. And it's them going back and going, okay, well, where was my areas of opportunity? Should I have ordered prophylaxis? Should I have screened better? Where could have I had better communication with the nurse about the VTE prophylaxis? So I really think it's inviting them, getting them involved. I mean, some of mine have published. I mean, you can do a lot. One may say no. You might have 3 no's to 1 yes and go with the yes. Just keep asking. I mean, every time I present somewhere, I always say, now who wants to join the team? Who's going to help me? I need help. And, usually I'll have one person come up and go, all right, I don't have a lot of time. That's how they always begin, but I have this much time. And I will meet with a physician at 6 o'clock or 7 o'clock. I really try to work with their schedule and also, maintain work-life balance. But you need your physician partners. You really do.
Mm-hmm, mm-hmm. Well, this is all the time we have for today. I want to thank you, Amy, for just an excellent discussion and overview and a list of action items on this topic today. I would also like to thank Cardinal Health for sponsoring today's webinar. To learn more about the content that was presented today, please check out the resources section on your webinar console and fill out that post-webinar survey. Thank you for joining us on behalf of Becker's. We hope you have a wonderful afternoon.
Thank you so much.